So at the outset, I would like to thank everyone for inviting me here and giving me such an interesting and difficult topic for debate. And I have a disclaimer that I am a radiation oncologist, not a medical oncologist, and I will try to do some justice to the topic given today.
The beauty of debate is this only.
Okay. So the thing is, topic is low risk early prostate cancer, post-radical surgery, local recurrence with high risk features and no metastatic disease, and we're going to talk for therapy. So what are the predictors of relapse on this prostate cancer? We have early biochemical failure, PSA doubling time less than 6 months, positive margins in surgical specimen and seminal vesicle involvement. These are the kind of factors which may tell us that a patient may relapse again. What are the sites of relapse? We see in literature 50% patient would locally relapse, but 50% would have metastatic disease with or without local disease. And these asymptomatic patients are difficult to diagnose or difficult to pick up early in prostate cancer thing. And why there is a need of more aggressive systemic therapy? Because as we know, 50% would fail distally with or without local disease. Hormonal manipulation alone may not be sufficient and need to strengthen systemic therapy for better systemic control of disease and of course to improve overall survival. So to address this particular question, of course, there is not much of a literature support or there are randomized data available, but in this landmark stampede trial, we get one arm which studied this particular situation, that patient who are operated previously and now they are relapsing. The surgery may be followed by radiation therapy or it may be without. So this particular subgroup that in which surgery is done and now they have relapsed without, see, this at least one. So PSA biochemical failure we have without nodal or metastatic disease because they have at least one of the criteria as a for labeling those patients as relapse patients. So this particular arm has an addition of docetaxel and zoledronic acid or both to first line long-term hormonal therapy in prostate cancer. And if we see this multi-arm trial has got a recurrent prostate cancer treated previously with radical surgery and they have relapsed with high risk features. Now,
Bhushan, your slides are not moving, Bhushan.
My slides are moving.
I think.
So shall I share it again?
I think better you share it again because.
Share it again and do it in the presentation mode. No?
Okay. I'll just exit.
Do it in the presentation mode and go ahead. Yes.
Now it is moving. Okay. Now it is moving. Yes.
And shall I go into presentation mode?
Yeah, that will be much better.
I was in presentation mode only. Now it's visible?
No.
Not in presentation mode.
I'll come out of presentation mode. Now it's visible?
It is visible, but
okay,
I'll
stay in this
presentation mode.
You please go ahead if you are comfortable.
Okay. So the allocation in this particular arm was standard of care, which was hormonal therapy. The second arm was standard of care plus zoledronic acid. And the third arm was standard of care with docetaxel. And the fourth one was standard of care with zoledronic docetaxel. So we have two arms which contain chemotherapy along with standard of care versus standard of care and zoledronic acid with standard of care. So if we go into detail, the accrual was 2006 to 2011. And radiotherapy was not mandatory in this phase of time of trial, and then after 2011 it became mandatory. So I'll come to this part later. The endpoints of this particular trial were overall survival and failure-free survival, and this is a trial schema of this particular thing, and with a good almost 4-year median follow-up. And this is an important table which has got all those 4 arms. And if you see these 2 arms which contain chemotherapy as a treatment to standard of care, and almost 50% patients of this particular arm were N0, which we are discussing about, and radiotherapy was not given in maximum number of patients, like almost more than 70% of patients did not receive radiotherapy in this particular chemotherapy arm. Since we know radiotherapy is a confounding factor in this situation, so more than 70% patients did not receive chemotherapy. So if we get into some compliance, all full 6 cycles could be received by more than 70% of patients, and more than 80% of patients could receive at least 5 cycles of chemotherapy. So compliance was fairly good. use of standard radiotherapy was across similar across all the groups. So, sorry, this was presentation mode. Yeah. So when we come to the results of this particular data, median survival and 5-year survival, only standard of care only arm was 55% versus standard of care with zoledronic acid arm was 57%, modestly better. But if you see the standard of care with zoledronic acid arm, the 5-year survival came to 63%, and arm which again contained docetaxel with zoledronic acid, it was 60%. So both the arms which contained docetaxel as a treatment modality had better survival, 5-year survival, than those two arms which did not contain docetaxel. So these are the graphs. This is a failure-free survival. 2 arms which contain docetaxel and 2 arms which did not contain docetaxel. And even in overall survival, you can see, of course, the difference is less as compared to failure survival, but still there is a difference. So docetaxel improved failure-free survival for non-metastatic disease as far for metastatic disease also. So in both the subgroups, it improved failure-free and overall survival. So addition of docetaxel standard of care was associated with improved survival and a difference of median survival of almost 10 months, as well as improvement in prostate cancer specific survival and failure-free survival, and skeletal related events were also less. And of course, docetaxel was well tolerated in this population, as we saw more than 80% patient could receive at least 5 cycles of chemotherapy. However, benefit of effect on survival is clear in larger metastatic subpopulation as compared to non-metastatic, because non-metastatic subset of men, death from other causes than prostate cancer were common, and that was the reason they could not really reach the significant difference as they could reach in metastatic population. And so in non-metastatic setting, there are insufficient mature survival results in the literature. So further follow-up and engagement in planned meta-analysis needed for further delineation of effect of docetaxel on survival in this particular setting. The impact of failure-free survival in both clear and large favor of docetaxel in stampede data. So to conclude, standard of care should be updated to include docetaxel chemotherapy in suitable patients, of course in metastatic disease, but it may be considered also in non-metastatic population with or without radiotherapy. Thank you. Dr. Manish Chandra is laughing.
Thank you so much, sir. I would now like to invite Dr. Manish Chandra for the radiation part.
Just a minute. I'll just share my drive. Is my presentation with you? Because here.
Yes, so your presentation is with us.
So I'm sharing it. Just a minute. Just see if it is possible. Is it visible?
Yes, visible.
Yes, sir.
Yeah. I must appreciate Bhushan for the kind of digging that he must have done to make some presentation. He was really on a wrong side. The topic given was really very, very biased. And I must say, he tried to create something, and I really feel I'm really appreciate the effort that he must have put in there. So just to start, in low risk prostate cancer post radical prostatectomy, local recurrence with high risk feature N0 and M0. So actually there is no debate that we has to go. Debate is over, but we have to go ahead and present some evidence. So if we see, first we have to just identify and dissect the problem that we have at hand. So our problem right now is we are dealing with a low-grade cancer of prostate, which underwent radical prostatectomy, developed local recurrence with no nodes and no distant metastasis, and high-grade features were present at this time. So which very clearly means there was a tissue diagnosis in this patient. That is why they could come up with a high-grade feature which was visible. And there was a MRI or a PSMA PET-CT was done after biochemical failure. So this is what we can conclude from the topic. So high-grade features could be high Gleason score, rapid PSA doubling time, positive margin on as we add a higher PRT PSA that is more than 0.5. So these are the few things where we are doing some assumption, considering that those informations are not available with us. So we are basically dealing with a recurrent disease where we have high-grade features. So how do we handle this issue? So practically, if we just understand, so if we understand what literature we have to find out, we just understand a very simple thing. We have to plan for a high-risk prostate cancer with no nodal or a metastasis. So our plan of treatment is very, very simple. We have to offer a long-term hormonal treatment with radical radiation therapy to prostate and seminal vesicle or pelvic node. This is what if this patient with a high-risk feature is coming directly to us. Will this patient at any stage of time will receive chemotherapy as a primary modality? No, the answer is very, very clear. There is no role of any chemotherapy at this stage. So guidelines for the treatment of CA prostate T2, T3, T4, N0, N0, the local treatment, radiation radiotherapy, till T3 nowadays radical prostatectomy is also done, but most of the patients require adjuvant treatment. So there is no role of chemotherapy. There was one trial that UG12, which randomly assigned 413 patients with high-risk prostate cancer to long-term ADT with and without 4 fraction of docetaxel and asbestin, without following staging pelvic lymph node dissection. There was no significant difference in the, this is important thing, there was no significant difference in the rate of metastasis-free survival and cancer-specific survival between the two arms. So there was no advantage when we tried to give this chemotherapy in a high-grade prostate cancer. There was no advantage. So since there was no advantage, then in that case, in a recurrent setting in the same patient, there is no reason why there should be any advantage. So if we come back to our case, there is a local recurrence with no nodal and no metastatic disease. So how do we manage this patient? As mentioned earlier, nearly all investigations are done. Tumor board discussion and decision. The most of the tumor board with a sensible members, the decision is going to be only one, that is salvage radiation therapy with to the tumor bed and pelvic nodes with ADT. This is what would be the suggestion. There is no role of chemotherapy or no suggestion of chemotherapy because we must have encountered similar case in our OPD, and this is how we would have planned and done our course. So there is, as I said, as Dr. Bhushan also agrees that there is no convincing data available for role of chemotherapy. Next thing is, what about the role of radiotherapy? Is there any data available? Yes, there is too much of data available establishing the role of adjuvant radiotherapy. But as far as it is the salvage radiotherapy or adjuvant radiotherapy, yes, we have randomized trial also, though a small one. But early salvage radiation therapy gives us a better disease-free survival. Data mainly that we are dealing with is a retrospective data with series and emphasis on the data, which is mainly emphasizing on what? The timing. When do we start radiation? Second is, what is the optimal dose that we are looking at and what is the volume that we are going to treat? So if we try to address each and every point, so time, if we see the early salvage radiotherapy, there is a data, the European Association of Urology. So when should we start? Which very clearly says, depending on the pathological tumor stage, almost 60% of the prostate cancer undergo radical prostatectomy will develop biochemical relapse. So when there is a biochemical relapse, the conclusion, this is very clear that if RTP is less than 0.5, then we have a better result as compared to when it is more than 0.5. Second, there is one more from the same group, prediction of outcome. When we are doing a early salvage radiotherapy, the only curative option is biochemical recurrence for local after radical prostatectomy. Early salvage radiotherapy leads to excellent cancer control in patient with biochemical relapse. For presumed local failure after retroprostatectomy, we developed the first. There was a nomogram which I am not developing because that is I'm not showing and discussing because that is not the discussion that we are doing. We are just establishing the role of radiotherapy here, and in this case, the patient counseling regarding the use of secondary therapy for individual after radical prostatectomy. Then regarding the dose, there is mainly the debate was between 60 gray or 60 gray, 66 gray or 70 gray. So whenever we are thinking of increasing the dose, the first thing which comes to our mind is about the toxicity. So this is the dose response salvage radiotherapy following radical prostatectomy. There is systemic review and meta-analysis, and this study provides the level 2A evidence for escalated salvage radiotherapy dose, at least at around 70 gray and probably higher. The presence of salvage radiotherapy dose response for microscopic disease after surgery supports the hypothesis that prostate cancer is inherently radio-resistant, and we all know that. That is why we try to deliver in a radical case dose close to around more upwards of 70 gray. This is what we are doing it. The second study that is from in the Red Journal publication was there, the salvage radiotherapy dose response in biochemical failure. This was again an observational study, multi-institutional. Higher RT dose was significantly associated with relative risk reduction, and 61% of the group that received more than 70 gray was free from biochemical failure at 10 years. So that's a very strong and important data that we have to look at. And with 43%, and when we see it's less than 66 gray group, it was 43%. So those point is more or less settled that we have to go for more than 66, because the third line, if we just see between 66 and 69.9 there and 70, there was no significant difference. So anything more than 66 or between around 70 is a dose that we are looking at. The worst outcome was observed whenever our patient presented with a high Gleason score. There was a high pre-RT level and an extra prostatic tumor extension was seen, and there was seminal vesicle invasion. So in conclusion, distant mets were observed in more than 25% of patients with Gleason score of 10 or tumor. So these are distant mets were seen when the patients had more adverse features. Now we come to the dose intensification and adverse reaction. So in these two studies that I'm going to present, in both the study, it was very clear that it is very well tolerated, and by increasing the dose, there was no corresponding increase in the adverse effect. That is the incontinence or there is a toxicity associated. So there was no difference between this. Dose escalation up to 72 gray demonstrated no improvement in 4 years with 66 gray. However, the dose escalation, so there was no improvement in the local control rate. But one thing is there, up to 78 gray also, late GU and GI toxicity remained same, and there was no increase in urinary incontinence. So the point that is emphasized in this study is that there is no advantage of going up to 70 gray. 66 to 70 gray appears to be an optimal dose. The second thing that we are establishing, even if we are going for it, so there is no increased late GU or GI toxicity. So this means that whenever possible, we have to go for an optimal dose. Don't try to go below 66 gray. So what are the results that, okay, this is what, so the long-term result which was there. So if we see, we evaluated in this study, the evaluation was all the patients who underwent salvage radiotherapy, and an undetected PSA level following salvage radiotherapy is more frequently achieved in men with a lower pre-radiation PSA and in those without seminal vesicles. So we have already discussed these points that without seminal vesicle involvement or lymph nodal involvement, these patients fall into a good prognostic group, and the patient has a durable 10-year survival, survival and a relapse-free rate. So in this case, this is what we have to say. We have a very robust data. We have a very important information with us where radiotherapy is the tool for local relapse, and we can take care of it with minimal or no toxicity. Then why there is a need of chemotherapy in these set of patients? Thank you.